there are some experiences with TCR T-cell therapy, which is a kind of immune cell therapy in sarcomas. Obviously, the initial experiences focused on synovial sarcoma, which express usually NY-ESO1 and also MAGE4, and the same for myxoid liposarcoma. So there have been single-arm clinical trials reporting very interesting activity in terms of partial responses. It's true that the majority of these patients can be treated with several previous lines. So some of the patients enrolled in these trials were heavily pretreated patients, and despite that, a substantial proportion of patients responded to this strategy. So I think this is also an option. It's true that the limitations is the restriction of HLA subtype, and also the expression, obviously, of the antigen NY-ESO1 or MAGE4. And in total, more or less 15-20% of patients with synovial sarcoma or myxoid liposarcoma could be treated with this strategy. And but it's also true that fine-tuning the options for the patients with this strategy, maybe my recommendations would be to treat in an earlier phase these patients, maybe in the oligometastatic disease or even in the high-risk localized disease. Why not? Can be very, very interesting to treat these patients. So the phase 2 trials have reported substantial activity, around 50%, and the proportion of patients with this shrinkage was even higher. But it's also true that in the end, the duration of the responses being adequate is not the expectation. This was less than expected. So I think there is an option for sure for these patients, because some of them, especially those with lower tumor burden, can be benefited. And then I think it's an option. But still, we need to fine-tune the recommendations, and maybe the very late phase is not the best option for TCR T-cell therapy.